Hello. Good afternoon. Team ready?
Yes, yes.
Can you hear me?
I can.
You can.
Let me check outside. Yeah.
Today's topic is LUF. Now, what is LUF? Any ideas? What is LUF? LUF is luteinized unruptured follicle syndrome. And where do you see it commonly? Have you heard of it? Where do you see it commonly? The commonest thing you see is you give somebody a trigger, ovulation induction is going on, either with Clomid or with HMG. You give a trigger and the follicle does not rupture. There is an LH surge, HCG is given, but the follicle does not rupture. Now, there is a huge controversy. Does such a system exist? Which means, does an unruptured follicle, luteinized unruptured follicle syndrome exist? It is debatable. You ask half the people in the world, they'll say no such thing exists. So, today, what we are going to see is what is luteinized unruptured follicle. Now, if you have a look at it, all the research done has been done prior to 1996. You know, at that stage, I was only 5 years old. It's a fact. And we don't have much data about it. So if you look at all the data of luteinized unruptured follicle, let's go to the basic. What is ovarian stimulation? COS, or controlled ovarian stimulation. And that is important to realize. One is it overrides the natural process. So in nature, the rule is one follicle, one egg. In COS, the aim is override it. Ovulation induction works for an ovulation. You do not do ovulation induction for women who are ovulating. So that concept has to be removed. Ovarian stimulation is for ovulatory and anovulatory women where you are giving more gonadotrophin, not less. And the aim is to override the natural selection process of follicles, give more follicles going. And that is the aim. Now, the question now comes up is in a selected number of women, they'll have something where ovulation does not occur adequately. And you could classify it in the olden times, as you call it, luteinized unruptured follicle. So what happens? Ovulation occurs, so there is an LH rise, but there is no ovulation. Odd, isn't it? So you see a rise of progesterone, you see endometrial changes, the endometrium starts becoming more whitish, but there is no proof of ovulation having occurred. And that is what you call as unruptured luteinized syndrome. The only way you can diagnose it is by an ultrasound. See, often we don't do an ultrasound after ovulation. Do you do it? No. That's the only way you'll know. We say it's a negative result. Now, how do you know it's negative? You will only scan them in the next cycle. Day 1, day 2, day 3. So as long as you scan them in the next cycle, you are almost never going to diagnose a luteinized unruptured follicle. You will never be able to diagnose whether ovulation did occur, whether there's a persistent cyst. You'll never be able to diagnose. Now, how do you diagnose it? You diagnose it mainly by ultrasound examination. There's a persistence of the follicle. So a follicle does not go down, and you start seeing that, you know, the clear picture of the follicle starts changing. It starts getting more white specks. It starts getting more irregular. You can see cells inside. And a lot of people would say that that is probably one of the causes of unruptured follicle syndrome. Come in, madam. So, does it exist again? It is debatable. Now, let's look at what the evidence says. Now, often the primary cause of a luteinized unruptured follicle happens when there is clearly anovulation. It also happens when there is unexplained fertility. So you see more unruptured luteinized follicle in infertility. You see them in pelvic pain, but often you see a good association with endometriosis. Now let's look at the evidence. There have been 2 or 3 studies which have been done. The first thing is, do you do follicular Doppler? It's worthwhile doing it. Not because it gives us a huge amount of data. There are people who believe that follicular flow tells you a lot. It doesn't. I think it's a gimmick over which you can place a lot of research. But what it allows you to do is it allows you to understand physiology. It's very simple. What happens to a follicle? Visualize it differently. When a follicle starts growing, what happens in nature? Blood flow increases. As blood flow increases, the follicle is being prepared for 2 things. It's being prepared for the most important event, that is ovulation. And post-ovulation, the most important event is the corpus luteum. So, see, in a laparoscopy, what do? We say don't touch the corpus luteum. Why? It's bloody. That preparation happens a long time ago. That preparation happens very much when a follicle grows, and that's exactly what a Doppler tells you. So when you see perifollicular flow, you're more likely to be able to say that's a follicle getting ready for release. Also, it is known that as your LH activity increases, perifollicular flow also increases, because LH starts making vessels more dilated. So again, polycystic ovaries, when you stimulate, that's one way to try and see if a follicle is nearing closer to ovulation. There's also a good belief that this is the debate. Is it the corpus luteum that is malfunctioning, or is it the oocyte that's malfunctioning? And there is some good data coming out is that the luteinized unruptured follicle is because of deficiency of granulosa cells. And there has been biopsy done on unruptured luteinized follicles where you see fewer granulosa cells compared to women who have had normal ovulation. So there is something which is going wrong in luteinized unruptured follicle, which we think is different. Now let's look at from the aspect of physiology. When does progesterone rise in natural cycle? We do so much progesterone.
Before ovulation? Just before ovulation?
Yeah, I'll give you 1 point. How many days before ovulation?
Not luteal phase, depending upon the cycle. 7 days before.
No, it's 2 to 3 days before ovulation, progesterone starts rising. It happens in nature. The reason is, we do so much of progesterone in IVF cycle, but in nature there is a small and sustained rise of progesterone. And there is some logic behind it, is that small rise of progesterone to a large extent is about
Sorry to interrupt. The Femex scans are running an hour and a half.
the LH rise is to a large extent dependent on that pre-LH rise of progesterone. So generally, there is a feedback mechanism that takes place. If your progesterone rise is less, your LH rise will be equally less. And the question is, what causes this rise of progesterone? The growing follicle itself causes that small rise of progesterone. And we know that there is a certain amount of feedback mechanism that exists. Now, anything that affects the early rise of progesterone, small rise of progesterone, will affect the amplitude of LH, which means if you have a very small rise of progesterone in a natural cycle, we may not be able to measure it adequately, but your amplitude, your rise of LH will also be affected significantly. Now, this seems to be again a defect in the granulosa cells. There seems to be something going wrong in the granulosa cells. Now, the question is, we know that this may be occurring very common. We know that there is a physiological logic behind it, that ovulation occurs. So there have been generally 2 studies done. In 1996, they had done a study on 31 cycles with the aim to look at luteinized unruptured follicle. And what did they do? They gave Clomid. Now this happens in many parts of the world. They gave day 2 to day 6 Clomid, Then they gave HMG from day 7 onwards, and it happens in many parts of the country. Now, HCG was given when the lead follicle reached 18 millimeter. After that, you did an ultrasound scan 7 days after ovulation. Okay, that's when we do day 21 progesterone. That's generally none of us scans 7 days later. Now, when you looked at that, 43% of women had ovulated completely. So there was a complete disruption, a complete collapse of the follicle. Surprisingly, 56% ovulated partially. So there's a partial collapse. And the rest, the follicle remained intact. There was no change. So there was a change in texture, but the follicle remained. And how it's been described? It's been described as being cystic. So you see a cystic formation. And where do you see it? They had a picture here. You know, sometimes you see a very large cystic follicle and we say, that may be a corpus luteum. So something like that. And you see that. It's a very cystic appearance. We say a cobweb appearance. And that may be a partial disruption of the follicle. Now there seems to be again the concept of a luteinized unruptured follicle is not a complete or a partial or complete phenomena. There seems to be variations. There are cases in which there is a partial disruption. There is a partial collapse of the follicle. There are cases in which there is no collapse of the follicle. So when somebody says it's a luteinized unruptured follicle, the question is what type of luteinized unruptured follicle it is. Is it a partially ruptured or is it a completely ruptured? Now, if somebody doesn't get pregnant on repeated cycles of treatment, repeated cycles of Clomid, you scan them on day 2 to day 3, you see everything is going on. The patient says, I'm not getting pregnant. What do you do? And one of the things which I tend to do is to say, let's scan you in the mid-luteal phase. Let's scan you on day 21. Let's see if ovulation has occurred. Now, is there any way of finding this out? One is by Dopplers. What do Dopplers tell you? Is if you have a corpus luteum, the corpus luteum Dopplers is very bloody. It's not perifollicle. You don't see blood flow around the follicle. You see a lot of flow inside. Now, that tends to be absent. So your blood flow, and you can do velocities, all that is, I think a huge number of headache work. But a simple question is add your Dopplers. If you can see that ring of fire, a round red ring, you know that ovulation has not occurred. And you see that very much in luteinized unruptured follicles. Now, the reason a lot of people say it doesn't exist is because we don't scan. If you don't scan somebody on day 21, then you'll never know whether that's occurred. The only thing that changes is the level of progesterone. And in that study which was done, they showed that there was a progesterone that dropped by half in a partially ruptured follicle or a non-ruptured follicle compared to a fully ruptured follicle. And that is day 21 progesterone. And that clearly indicates that your luteal phase progesterone seems to be affected with an unruptured luteal follicle, which either means that the LH surge which has occurred, at the end, all our endometrial support is based on LH type activity. So your LH type activity depends on your surge. If your surge is poor, your LH type activity is going to be limited. The other thing which possibly could occur is there is a problem with your FS, the threshold of the follicle, which means some follicles are going to have a premature LH surge. And we know that about 10% of follicles will have a premature LH surge at about 15 or 16. Now, the question is, if such a thing does exist, how do you treat it? Treatment? Any suggestions? Perfect. He's the expert now. He's right. So we know that there is an inadequate LH surge. There is a problem with the follicle not collapsing. There's a suspicion that the egg has not been released. There's no way of confirming that, and that is the biggest challenge. There's no way of confirming whether the egg has been released. But the presence of a follicle that even after LH surge, even after HCG remains persistent is a suspicion of luteinized unruptured follicle. Now in those cases, what does research tell you? What is better? Is it better to try Clomid? Okay, if you see Clomid, if you give Clomid to somebody who has an unruptured luteinized follicle in nature, it reduces the incidence of luteinized unruptured follicle by just 12%. In fact, Clomid may be one of the causes of luteinized unruptured follicle. Why? Because it keeps a relatively high LH. What does clomiphene do? It releases FSH and LH from pituitary. So it keeps a relatively high LH level. Now in those cases, if you're having this on Clomid, the aim is stop Clomid. Do not use Clomid. The next option is what happens if you give only HCG as a trigger. You decide, let's not leave it to nature, let's intervene. By giving HCG as a trigger, you reduce about 46% of unruptured luteinized follicles. So we know that in these cases, when you trigger at 18 millimeter, at 17 millimeter, you may be able to lower the chance of luteinized unruptured follicle. But the most important thing is to go back to the basics, is stimulate the ovary. Allow the ovary to...
Sorry to come in again. I've got this couple who's come through. She's on Proganova. She's already taken her Proganova. She's due to start her injections on the 25th. Don't laugh when I say that. He's got a cricket match in Dubai that he can't get out of. It's really important to him. The final's on the 6th of February. We can't guarantee that he's going to be back in time for stimulation.
Okay. Can she continue Proganova for another few days?
Can she? I don't know.
Yeah.
How long can we continue Proganova for?
She's supposed to start on 25th.
Yeah.
She can continue till 1st of February.
Yeah.
So can I get somebody just to review the notes after
Yeah.
the meeting and I'll call her back? Yeah.
Now, what keeps a constant breaking of FSH threshold, what keeps the follicle growing constantly without a decline of FSH, early decline, is gonadotrophins. Gonadotrophins certainly do better than clomiphene. Now, if you use gonadotrophins, which means that if you use HMG 75 per day and you use HCG, 95% of luteinized unruptured follicle will be prevented. So if you see a persistent rise of follicles, you scan somebody on day 21, you see persistently that follicle is remaining persistent, and your diagnosis of a luteinized unruptured follicle is being persistent. In those cases, go on to the mild stimulation protocols, what professors, low dose chronic protocols, give them 75 of HMG and give 75 of HMG every day, remembering that a small proportion will still have a premature LH surge. That is one of the problems which always occurs. But in those cases, if you use HCG 10,000 international units, not 5,000, 95% of your luteinized and ruptured follicle will go. And that's probably one of the best treatments to do. So in summary, there may be something like an unruptured luteinized follicle. There's absolutely no way of proving that ovulation has not occurred. It is not an all or none phenomena, which means there are some will have a complete decrease in follicular size. There's some will have a partial decrease, and there will be some where the follicle continues to persist with changes inside. So it will be cobwebbed, it could be disruption of follicular cells. The treatment is based on correcting a defective follicular phase. Clomiphene is not a very good treatment. If there's somebody on clomiphene, stop using clomiphene. HCG is a good intervention, but the best treatment is to use chronic low dose. That's what we do here. 75 every day and give HCG trigger. A small proportion will have a premature LH surge. Any questions? Any questions for anywhere? We've got a lot of visitors here. Can you use LUF? Yes. All the studies, remember, were done in 1992 to 1996. That's a time when reproductive medicine was in its infancy and HMG was the only drug used. Can you use LUF? Absolutely, yes. It's the same logic. Use HCG triggers and your chances of having that syndrome are relatively less. And that is not what I say, it is what research says. So, somebody asked me if I can review luteinized unruptured follicle, because everyone asks this question. You look at people who are doing in private practice and they'll say, yes, such a thing does exist. And the question is, does it? We say no because we don't scan them on day 7. And if you really want to diagnose it, you should be scanning somebody 72 to 96 hours after a trigger to see if that follicle has ruptured. And you'll see that only 50% of follicles will rupture. 50% don't. Partial or some will remain there. In those cases, if you revert to giving them gonadotrophins, giving them 75 units every day or 50 units of LUF or Pyrogon every day, your chances of having the absence of an unruptured luteinized follicle will be less, almost by 95%.
Can't you give only the trigger without mild stimulation?
Sorry, you can. That's what the evidence says, that even if you just give an HCG trigger, even in those cases, you give a reduction by 50%. But a lot of cases where you see a luteinized unruptured follicle are when you have given clomiphene. Next, you've given clomiphene, you give a bit amount of HMG, and then you give a trigger. And then you see that on day 21, the follicle has not ruptured. So in those cases, revert back. Avoid using clomiphene. Go back to gonadotrophins. Give 75 gonadotrophins. And you give a much better chance. So what I tend to do is, let's say, 1 or 2 cycles of clomiphene have not worked. I tend to say, let's do a day 21 scan. Let's do a day 21 progesterone and let's do a day 21 scan. And if your follicle is still large there, that may be one of the diagnoses. But there's absolutely no way of proving it. It is very much a circumstantial evidence backed by lower progesterone, a scan showing a disrupted follicle with blood flows that do not resemble a corpus luteum. So it's everything based on circumstantial evidence. Okay, so let's